Next is about Guillain-Barré syndrome, which is a continuation of the neuropathies. Now, it's also a sort of neuropathy. Guillain-Barré syndrome is a sort of neuropathy, and historically, in 1859, author called Landry published reports of 10 patients with an ascending paralysis. Subsequently, in 1916, three French physicians, Guillain, Barre, and Strahl, described that two French soldiers with the motor weakness, areflexia, cerebrospinal fluid albuminocytologic dissociation, where there would be a higher protein content in the albumin, and they described about the pathology, and hence that name continues as Guillain-Barré syndrome. The Guillain and Barre are the two names as such of scientists who had documented and then maybe established that. Now, anyway, it's not a single disease. It's a clinical syndrome, a group of clinical syndrome which can present with the inflammatory pathology of involving the radicals of the nerves. Now, earlier, the poliomyelitis was one of the most common variety of the pathology, which had produced the lower motor neuron palsy in these conditions here, of course. Now, as the poliomyelitis is almost abolished, like after the immunization, the commonest form of the neurological pathology, particularly lower motor neuron pathology seen, is that of the Guillain-Barré syndrome. Is a post-infective neurological pathology. Of course, as in case of poliomyelitis, there may not be a permanent damage to the Schwann cells, but there would be an edema of the Schwann cells in this condition too. Now, based upon the clinical presentations, they are again categorized into that subgroups of acute inflammatory demyelinating polyradicular neuropathy, where the Schwann cells, particularly the radicular nerves, that's the spinal ganglia, upper motor and lower motor neuron junction, would have a demyelinating changes, or the axons also may have the neurological changes, like, and that condition is the most common variety of the presentation. Majority of the patients whom we see would be of that category, where there would be polyradicular neuropathy, and that's exactly the situation now. The other formation could be other changes, would be subgroups would be acute motor axonal neuropathy, where instead of the spinal ganglion being affected, the axons may be affected in such conditions, and that's the axonal neuropathy, another of the condition, which may have a lesser chance of recovery. See, that polyradicular neuropathy has a very high chance of spontaneous recovery, whereas motor axonal neuropathy has a comparatively lesser chance of recovery. And then motor sensory axonal neuropathy is another condition. Miller-Fisher syndrome is another condition, or which may be presented as such a pharyngeal cervical variant or pure sensory GBS. These are the other variants which are not very common as such. Now, it's defined as the GBS or Guillain-Barré syndrome is defined as a post-infectious immune-mediated disease targeting peripheral nerves, and up to 2/3 of the patients report an antecedent bacterial or viral illness prior to the neurological symptoms. And Corynebacterium jejuni is the most common in other organisms. So, the routine in the neurological practice is patients presenting with the neurological pathology, they would be investigated for Corynebacterium jejuni, either the active presence or the antibodies of the Corynebacterium is routinely investigated, because it covers around more than 60% of the patients where the Corynebacterium jejuni is the primary infection. The other conditions which may be related to are cytomegalovirus forms, the second common factor. Relationship with the COVID-19 is now being established. Patients who have COVID-19 also have a higher chance of Guillain-Barré syndrome, and since the past 2 years, the incidence of Guillain-Barré syndrome is increasing because of that COVID, and there is a huge controversy like whether the COVID vaccination has resulted in GBS syndromes or not, Guillain-Barré syndrome or not. Throughout the globe, there is a lot of controversy around it, and the WHO was forced to give a publication like it's not related, like the relationships are not significant and the incidence is not so common. Of course, there is a controversial issue like whether the vaccination increases the chance of Guillain-Barré syndrome or not. a lot of publications, huge number of publications have come up where these relationships are established, but at the same time there are lots of other way also, the presentations and publications which statistically disprove this. So it's still controversial, but the controversy has become so vast that WHO had to give a clarification and a propaganda material to say that disadvantages of a possible Guillain-Barré syndrome is lesser than the advantages of the vaccination. Anyway, that's the other issue. The other suspected causes are repeated penicillin administration. Patients who are treated with the penicillin for repeatedly, they have a higher chance of that. Then another very much established reason is that misuse of motility reducing drugs like Imodium, that's loperamide, or diphenxylate or Lomotil, which most of the times the people would keep them in their pocket as a non-prescription drug or on-the-counter drug like, and the moment they have some loose stools, they tend to take the medicines like loperamide or Lomotil. And this is established now. This relationship is now established quite significantly related to the drug Guillain-Barré syndrome as such. Those who have that habit of misusing this drug, unnecessarily taking these drugs, they have a high chance of developing the Guillain-Barré syndrome. Particularly after a Corynebacterium jejuni intestinal infections, those who have intestinal magnification, this manifestation, and they treat with the Imodium or diphenxylate, which is very common prescription in the contemporary practice, they have a high chance of that. Then the other drugs which are now almost known to have some relationship with them, the development of GB syndrome or streptokinase which is used in cardiac medicine as a clot buster, isotretinoin, danazol, captopril, and gold and heroin. These are certain of the drugs which are now known. Otherwise, even stress-inducing conditions like surgery, trauma or pregnancy also have been considered as a possible triggers of GBS. These are all the known statistical relationship with the GBS, but none of them is absolutely proved. An absolute proof is not yet possible in any of that. The clinical course of the disease is, it always starts as a sudden onset of neurological deficit, particularly lower motor neuron pathology, and the course is relatively rapid. Most of the times the patient would have a tetraplegia, all the four limbs involved, within 24 hours, and usually the weakness would be increasing day by day, and the maximum would be always reaching by around 10 to 14 days. And the mortality rate of Guillain-Barré syndrome varies widely, ranging from 1 to 18%. Particularly even after the ventilation. Now, one of the major important part of the management would be, because it is the lower motor neuron involved, respiratory muscles will be involved, and hence the patients may have a respiratory paralysis, and hence Guillain-Barré syndrome patients in the initial stages, they may require ventilatory support, and even after that ventilatory support, the mortality rate is around 1 to 18%, which is comparatively high, and it increases with the age, ranging from 0.7% for people under 15. In the younger age, the mortality rate is lesser, but the older age, the mortality rate is increasing, and most of the times the patient may require a ventilator treatment because of the neurological pathology. And ventilator treatment, average duration of the ventilator support is something around 50 days. The patients have to be kept on ventilator for quite a long time till the patient recovers, though there is a chance of spontaneous recovery. Now, the issue is the clinical course of the disease is so rapid that it's difficult to say which of the patient will go into a respiratory failure, and hence all the patients, they need to be kept ready for the ventilation, and usually if the course is rapid, they tend to have higher chance of this requirement of the ventilation, and though the patients may recover, the patients being kept on ventilator for a long duration can result in more harmful complications, or the complications of the ventilation itself can be more harmful as such. And These days, with the intravenous immunoglobulin, the duration of need for ventilation may have been slightly reduced, but still it is almost nearly the same. Now, usually patients would recover, and most of the times, by around 80% of the patients, would be able to walk independently by 6 months, and 60% of the patient may attain full recovery and motor strength by about a year. So, time taken for the recovery also is a relatively longer. Now, factors which lead to poor outcome. When a patient presented with the Guillain-Barré syndrome, initially with the typical neurological pathology, where there could be a flaccid paralysis occurring in the limbs, the prognosis could be predicted. One of the major risks is when the patient requires ICU requirement, ICU treatment, and the usual predicts poor outcome predictors are a patient developing the GBS after gastrointestinal infection, like diarrheal illness, which is a Corynebacterium pathology, and such patients who are treated with Imodium or denoxipylate drugs like that, motility reducing drugs, they have a high chance of developing these complications, and there again the outcome will be poor. Older age, 57 years or older, statistically this is the cutoff limit where the prognosis becomes suddenly poorer. And patients who have involvement of the upper extremity, they also have a higher chance of developing. See, usually the clinical presentation would be starting with the lower limb, the distal most part, and then it ascends up. That's the usual presentation. As long as the pathology is limited to the lower limb, you may not have a risk of involvement of the respiratory structures, respiratory functions. But when the upper limb tends to get involved, there is always a high possibility that it may result in the involvement of the respiratory system, and that's the first sign, like the patient may require a ventilatory support. And such patients who have a upper extremity involvement, poor strength in upper extremity, they also have a high risk of developing more and more serious complications, and the outcome would be poor. If the patient had to stay in the hospital for longer than 11 days, and if the patient requires a mechanical ventilation, if the failure has resulted in or the respiratory failure has resulted in a mechanical ventilation requirement, in that condition too, it suggests a poor prognosis. Another predictor of the prognosis is based upon what we call as the MRC score, or Medical Research Council score, which is below 40. MRC score, or Medical Research Council Muscle Power Scale or score, is based upon assessment of the muscle strength in different segments: shoulder abductions, elbow flexors, wrist extensors, hip flexors, knee extensors, and the foot dorsiflexors. These groups of muscles are assessed individually with the usual grade of muscle strength, like starting with grade 5 to grade 0, and then you score. So total score would be 60. If the total score is more than 40, if it's less than 40, 60 is normal in a normal situation. If the total score is less than 40, that patient would be having a high risk of developing the complications. That's one of the measures which is now considered as a benchmark measure for predicting the outcome in case of GBS as such. So, any patient of GBS, you will be studying these muscle strength in individual groups in terms of shoulder abductors, not the individual single muscles, groups of muscles, with the left and right, again elbow flexors, wrist extensors, hip flexors, knee extensors, foot dorsiflexors. These groups of muscles are assessed there for the strength, and then the score is put on. And if the score is less than 40, the patient would have a high risk as such. The pathological changes which occur in case of Guillain-Barré syndrome are considered as mediated through the antibodies, particularly Corynebacterium pathology. It produces an immune response, and its antibodies are produced from within the lymphocytes, and these antibodies would be producing the damage to the axons. The myelin sheath would be affected, and the myelin sheath area would have lesser amount of the adenosine diphosphate, and hence the conduction would be affected, resulting in the lower motor neuron pathology. Now, to confirm the diagnosis of GBS, none of the investigations would be absolutely specifying this confirmation of the diagnosis, and hence there is most of the times it's based upon the clinical evidences. The clinical evidences are now the organization of neurologists have now put some specificity. The features which are required for the diagnosis of the GBS is a progressive weakness in legs and arms, sometimes initially only in the legs. And the classic clinical picture of a weakness is ascending and symmetrical in nature. That's it starts with the smaller muscles and usually the distal most muscles like the phalangeal muscles, they are involved, and then gradually it ascends up. That gradual ascending up progression is one of the characteristic feature. And absence of the reflexes or decreased tendon reflexes in weak limbs. Now the usual would be patient starts with the finger dysesthesia, the symptoms in the fingers where the patient may have either numbness or maybe pain or tingling sensation, etc. And then it becomes muscle weakness, which involves the lower limbs. And weakness may progress in variable speed, like in some it may occur within a few hours and it may extend, in some it may take days as such. And it also can involve the truncal muscles of the muscles of the thorax and abdomen. Cranial nerves also can be involved, and the important and the critical would be muscles of respiration. And rarely some of GBS variants may present as a motor dysfunction. It may not be total weakness, but abnormal functions like tremors or fasciculations or at times involuntary movements also can be presented as the symptoms of GBS. Now, the clinical presentations would be again which give you a clue to make the diagnosis. Now, all these important clinical clues are important to make the diagnosis because there is no definite evidence of confirming the diagnosis of GBS. The clues are up to 2/3 of the patients would have a previous illness, something like febrile illness or an infective illness before the onset of this. Patients who have upper respiratory and gastrointestinal illness are most commonly reported conditions. Usually, previous either upper respiratory infections or gastrointestinal tract illness is the most common preceding condition as such. And symptoms generally have resolved by the time the patient has the presence with the neurological conditions. That previous infective pathology would have resolved, and usually the maximum duration gap between that previous infective episode and onset of the neurological pathology is around 2 weeks. So within 2 weeks, in the past 2 weeks, patient might have a infective pathology involving the respiratory or gastrointestinal tract and might have recovered after treatment, and then he develops the neurological pathologies. Now, when the other variants, majority of the patients start with the distal most lower limb and then the presentation. The other variants could be some of the patients may present with the cranial nerve involvement, and the cranial nerve involvement is observed in 45 to 75% of the patients with the GBS, and cranial nerves, particularly 3rd and 7th or 9th and 11th are more commonly, 9th and 12th are more commonly involved, and they usually present with a facial hook. That's something like Bell's palsy, which may look like Bell's palsy, but not the whole of the facial nerve being involved. Or the patient may present with the symptoms like diplopia, double vision, dysarthrias, dysphagia, which are all characteristic of the cranial nerve involvement. Or the patient may have ophthalmoplegia, where the vision movements of the eye could be affected, or even there could be abnormality of the pupillary reflexes. But these are comparatively less common presentations of GB syndrome in the initial stages. Then another group of the patients, as you have subgroups, like there could be one group of the patients who may present with the sensory changes. Sensory changes in the Guillain-Barré syndrome also are not so common. They are not seen in every patient. But a few of the patients may present with the sensory symptoms which can complain of either paresthesias, that's altered sensation, numbness, or at times it could be changes of sensory, like instead of touch sensation they may consider this as a pressure and so on. So there could be a altered feeling, like, and sensory symptoms often precede the weakness. Before the sensory this motor weakness occurs, the patient may have a sensory symptom, then the patient develops the neurological pathologies. That's the usual presentation. and usually it starts in the toes or fingertips and progressing upward. That's the usual presentation as such. Then another of the set of the symptom could be pain symptoms. Pain which is usually related to the muscles, where the patient may have cramping muscles or tenderness in the muscles could be the presentations as such. And are patients with the immobility who are the pain associated with the conditions of immobility also like because the patient is not able to move, there could be pressure on the nerves and hence the patient may have pathology, or ulcers also are common, bed sores are common. Then most of these patients of Guillain-Barré syndrome also tend to have autonomic changes, the involvement of the autonomic nervous system, and it can present with either tachycardia or bradycardia, or a patient may have a flushing, hypertension, acute episodes of hypertension, suddenly the pressure rises and then again it may come down, or it could be orthostatic hypotension, like patients in the initial erect posture may have a significant hypotension, or anhidrosis or diaphoresis, like either excess of sweating or absence of the sweating also can be the presentations, and a good number of patients of GP syndrome would have involvement of these, and particularly autonomic changes, tachycardia and bradycardia, they are danger signs. Some of the patients may even succumb to cardiac arrest. Patients particularly present with the abnormality of the cardiac rhythm, tachycardia or bradycardia, they have a high risk of going into a cardiac arrest, and hence such patients also have to be treated carefully. And again, such sudden developments also would occur usually within first 1 or 2 weeks as such. Then respiratory involvement is the most critical issue. Any patient presenting with the GB syndrome has to be considered as a potential risk for respiratory involvement, and some patients particularly who have either upper limit involvement or oropharyngeal weakness, it can be considered as the sign of respiratory involvement, and the symptoms initially starting with could be dyspnea and exertion or shortness of breath or difficulty in swallowing or slurred speech. These could be the initial symptoms which predict that the patient is going to have a respiratory involvement, and such patients have to be immediately shifted to a center where the respiratory support facility is needed. Course of the disease is usually like initially there could be an infection, and hence during that period there will be no weakness as such. Now these graphs would show you the typical presentation. The infective pathology would be first a few days, then the neurological pathology starts after a gap as such, and then gradually it can just neurological pathologies can result in severe weakness reaching to the stage of paralysis, and then there could be a spontaneous recovery by around 12 weeks. During this period, if you study the antibodies, the anti-ganglioside antibodies, which is the antibodies which could be specified for the neurological pathology, the antibody level also may reach the peak at the time of onset of the neurological pathology, but gradually it gets reduced. So the diagnosis of exact diagnosis of Guillain-Barré syndrome becomes difficult, because if you have the facility for assessing these antibodies as such, still there could be a situation where you may miss this, because it depends upon the time in which the blood sample is taken, and majority of the patients would go to a center where these facilities are available by the time they have that maximum weakness, and at that time the ganglioside antibody level would be getting reduced, diminished as such. So peak antibodies level would be seen almost simultaneously at the onset of the neurological symptoms, and chances of getting an investigation done of these antibodies at that moment is comparatively lesser, particularly in our condition. So that antibodies investigation also would be comparatively less useful practically. Now, to make the diagnosis of Guillain-Barré syndrome more easy, the pattern of the distribution of the motor symptoms in Guillain-Barré syndrome and sensory symptoms, patterns which could be seen, they are now presented as a graphical issue which can help you to make out the diagnosis. The motor symptoms presented with the reddish lines, sensory symptoms presented with the bluish lines, and decreased consciousness only in a few of the patients. ataxia or alternate gait in these patients. Now, with the variants are subgroups of the Guillain-Barré syndrome, which we have discussed in the beginning, which we have referred to in the beginning. The distribution of the lesions could be of different as such. A classical majority of the patients would be having motor as well as sensory symptoms, which can involve whole of the body, starting with the lower limb, then ascending up. A pure motor pathology also can present with the similar situation where it starts with the distalmost part, then reaches to the proximal. And a paraplegic where it is only the lower limb is involved. A pharyngeal cervical variant, which we have discussed earlier, referred to earlier, that where the lower limb may not be involved, it could be on the upper limb involved, and these patients have a very high risk of developing the respiratory pathology. Then facial palsy could be another of the symptoms where the patient may have facial palsy as well as paresthesia. A pure sensory symptoms also could be seen in such patients in the lower limb, or there could be only the pure sensory symptoms in the distalmost part of the limbs, both in the upper and lower limb as such. Or there could be Miller-Fisher syndrome where the patient may have abnormality of the movement only, ataxia. The motor dysfunction could be there, but may not be a deficit. It is called as Miller-Fisher syndrome. Of course, not so common. Or it could be like a very severe brainstem encephalitis condition, where you may have all the set of symptoms along with the decrease of consciousness. These could be the variants of the clinical presentation. Now, as well as the variants which we have discussed again, the clinical presentations could be the classic sensory motor, which constitutes around 30 to 85%. The clinical presentation would be, which we have discussed, like rapidly progressive symmetrical weakness and sensory signs with the absent or reduced tendon reflexes is the most common presentation. Then the pure motor, which constitutes around 5 to 70%, there could be a motor weakness without sensory signs. There may not be a loss of sensation. These constitute the majority of the patients. Now, comparatively, the incidence in a paraplegic where there could be only paresis restricted to the legs, it's only 5 to 10%. Then pharyngeal cervical is less than 5%, where the patient would have pharyngeal, cervical and brachial muscles, the same graph which I have shown there. And bilateral facial palsy again less than 5%, and pure sensory is less than 1%. Miller-Fisher syndrome also is around 5%, less than 5%. These are the set incidences of the pathology. So, our most common clinical focus would be on sensory motor and pure motor pathology. As I told you earlier, diagnosis is mostly clinical. Nerve conduction studies also do not confirm, they confirm only the demyelination, but whether the demyelination is produced due to the sclerosis, systemic sclerosis, or whether it is due to Guillain-Barré syndrome, that cannot be made out exactly with the nerve conduction studies, and only the picture has to be correlated with the clinical presentation, and then you make the diagnosis there. Lumbar puncture and CSF studies also are one of the tools by which the diagnosis can be made, and the protein level of more than 400 milligram in a large number of patients are seen. But again, that's not confirmatory, because in a good number of patients the protein level may still remain normal. A higher level of proteins may suggest of inflammatory pathology involving the central nervous system, and that may help in confirming the diagnosis of GB syndrome. MRI also is comparatively sensitive, where you may see thickening and enhancement of the conus medullaris and nerve roots, as you see in this image. Like, see at this area there could be thickening, the evidence in the MRI scan, the thickening and the the dye concentration would be more, as you see in these images, or in the transverse image also in the spinal cord, that dye concentration and thickening can be better made out in this image. So, MRI scan is somewhat sensitive, again not very accurate, the sensitivity is lesser, but when you see these findings, the Guillain-Barré syndrome can be diagnosed better. Now, in all the Guillain-Barré syndrome patients, the most risk factor would be whether the patient would be requiring respiratory support or not, and the respiratory insufficiency has to be assessed as such to decide whether the patient requires respiratory support or not, ventilatory support. See, the major two issues which can produce a fatal outcome are either respiratory failure or a cardiac arrest. Now, respiratory failure is a progressive condition, and a correct detection of the need for respiratory support is one of the crucial issues. And it's done by a standard scoring method, which is called also EGRIS score method, or Erasmus Guillain Barre syndrome respiratory insufficiency these scores. The score is decided by the factors like days between the onset of weakness and hospital admission, how far the time taken for onset of the symptoms and by the time the patient has come to the hospital. If the patient has come to was necessitated to come to the hospital, like with the neurological pathology, early within 3 days, that means there is a higher score. If the course of the disease is slower and the patient has come after about 7 days as such, then the score is lesser. If the patient has a facial or bulbar weakness symptoms, then the score is 1. And MS score, which we have discussed initially, that muscle power score, that is another of the factor. If it is between 60 to 51, it's 0. If it is less than 20, the score will be 4. And score of more than 4 would be requiring essentially ICU admission, and such patients have to be treated in the ICU till the patient shows the sign of recovery. Then another method, that's one method. Another method of doing this would be respiratory insufficiency test, routine respiratory insufficiency test in all the patients. This is true in all the patients. It's not only in the Guillain-Barré syndrome. Any of the patients who have a breathlessness at rest or during talking, inability to count 15 in a single breath. That means there is a significant respiratory insufficiency, and such patients will require either various levels of respiratory support. See, levels of respiratory support could be anything, like it could be simple oxygenation given either with a cannula or maybe a mask as such, or maybe ventilation. That levels of oxygen administration we have discussed in the beginning of our emergency medicine classes, like if you remember that, you can make out that. Or if the patient shows the signs of accessory respiratory muscles or increased respiratory heart rate, if the vital capacity is less than 15 to 20 milliliter per kilogram or less than 11 as such, then arterial blood gas is altered, and blood gas oximetry, if the oxygen concentration in the pulse oximetry is less than 80%, that patient requires essential respiratory support. That's how it's done. So in all patients, these are the issues. Now, once the patient is shifted to ICU, the management of the ICU in the ICU would be particularly respiratory therapy to keep the patient ventilated, then cardiac monitoring, nutritional supplementation. These are the basic issues of the treatment. Then another of the issue would be, once the patient is in ICU, there is always a possibility of infections, higher chance of infection, infectious complications don't occur, and that has to be monitored and that has to be treated. So there is no specific curative treatment for Guillain-Barré syndrome in the ICU, but ICU would be only to keep the patient alive till he recovers. Now, the other standard treatment now, which is used, is intravenous immunoglobulin and plasma exchange. These are considered as a standard treatment by which the recovery is higher and the risk of complications is reduced. They are claimed to be like that. And earlier there was a practice of using corticosteroids before the immunoglobulins were brought to use. See, intravenous immunoglobulin was brought to use in late 80s, 1986 or 87, something around that. The immunoglobulins were started, and in India we could get that immunoglobulin only in later 90s, later half of the 90s. Till then it was not available. So earlier corticosteroids were the standard treatment, but now it's now seen that corticosteroids are not useful in patients of Guillain-Barré syndrome, but corticosteroids are the treatment, standard treatment for transverse myelitis, which has a very similar presentation. So that makes the issue complicated, but the issue is exact diagnosis of a transverse myelitis and the GB syndrome. Difference between these are very minimal, and that exact diagnosis is often difficult except a few CT findings, which we will be referring to. That transverse myelitis I will be dealing with somewhat in detail later, next after that. So in transverse myelitis, corticosteroids is the benchmark treatment, whereas in GB syndrome, it's not useful or not necessary. But what happens is practically every patient would be given corticosteroids because you are not able to make out that along with the immunoglobulins. That is the real situation. Anyway, and the dosage of immunoglobulin is 0.4 grams per kilogram to 2 grams per kg, which is a related, the dose is to be determined based upon the sequence, severity of the pathology, and the frequency of the treatment may be vary from once in a week to once in every few months. And the cost in India now, the current cost is 12,922 to 15,002. Different brands of this cost would be around 100 ml bottle, and 100 ml bottle contains 5 grams of immunoglobulin, and the cost per gram is around 2,584 to 3,040. Now you assess the cost of the treatment. 0.4 grams per kg is the dosage. If a patient is around 50 kg, then his requirement will be around 20 grams, and 20 grams would cost 2,584 into 20, you calculate it. So that makes the issue of GB syndrome treatment quite difficult and costly. Then the other technique which is often done is plasmapheresis. Plasmapheresis is something like the hemodialysis, where the plasma is separated and the immunoglobulins are separated. These days this treatment is becoming popular very recently, but what I have seen is many of the patients may not have such an excellent recovery compared to the cost of the treatment and difficulties involved. Now when a patient comes to us or comes to me in with these presentations, if the patients present in the first 1 week, I would not treat the patient because I do not have an ICU facility where the respiratory support is required, and that responsibility would be quite difficult. And hence, main standard protocol is if a patient presents with the GB syndrome in the early first 1 week, definitely I would be referring the patient to a facility where ICU treatment is available. When the patient comes later, so majority of the patients whom we treat would be coming after this, where the patient may have a residual neurological deficit which is persisting beyond that usual duration. In such conditions, the treatment which has given a significant benefit would be same treatment of Pakshagata, Chandraprabha, Ekamira, Bhrakatapyadi, Mishrana, and Agni Chikitsa with Matra Basti, and we have treated a good number of such patients with the significant benefits as such. Then the next condition which mimics this GB syndrome and almost producing the confusion is a transverse myelitis. So for practical purposes, the differentiation between these two is very difficult, and most of the times the diagnosis is done only when in the later phases where the patient may not have a recovery. See, transverse myelitis patients as a rule would not have a complete recovery. There will be some amount of neurological deficit even after the phase of recovery, whereas Guillain-Barré syndrome, almost more than 90% of the patients would have a complete recovery if there are no fatal complications occurring in the initial stage. So most of the times, for all practical purposes, differentiation of transverse myelitis and Guillain-Barré syndrome comes at the later phase. Of course, in a very high sophisticated center, there could be a differentiation based upon the other clues. So most of that, whatever we discuss about these differences now, would be of some theoretical interest for in our setup than really practical. Very few of the things may be practical like. Now transverse myelitis is comparatively rare compared to GB syndrome. It's less frequent. It's also a acquired focal inflammatory disorder presenting with the similar symptoms like rapid onset of weakness, sensory deficits, and bowel and bladder dysfunction. There will be more frequent involvement of the autonomic nervous system, and hence bowel and bladder dysfunctions tend to occur. Generally occurs at the spinal cord level and can mostly present at the thoracic level. Unlike that of a typical GB syndrome which starts at the distal most part and then ascends up, transverse myelitis may start at any one segment and then it may ascend up as such or descend down also. The symptoms may vary, it may course may progress in any manner. Etiological, majority of the conditions idiopathic, where the exact causes are not known. Then post-infectious or systemic inflammation is other, and the identified infective pathologies which can trigger the transverse myelitis are West Nile virus, herpes virus, HIV, and T-cell leukemia virus, Zika virus, or neuroborreliosis or Lyme's disease, mycoplasma, treponema. These are the identified organisms. Difference between the GP syndrome and transverse myelitis is based upon the initial triggering infections only, which in a real practical clinical situation becomes somewhat less relevant, because we may not go into these kinds of the identification of the organisms, but in a sophisticated center, more theoretically, and in a setup where the specific antibodies of these organisms can be assessed, these can help. The organisms which produce these are slightly different. So that's all the issue. Clinical presentation, usually it can be varying as either acute, as in case of Guillain-Barre syndrome, there could be a sudden and rapid course, or subacute, gradually progressive pathology. Initially, the patient presents with the paraparesis, that both the limbs are involved, and it can be varying. Unlike that of Guillain-Barre syndrome, majority would be starting with the lower limb. It can involve upper extremities initially, and then the flacidity follows by spasticity. Initially, as in case of the Guillain-Barre syndrome, initially flaccid, then it becomes spastic. Sensory involvement with the pain, dysesthesia, paresthesia at the level involved. So it may start at one level, very often thoracic level, then either it may ascend up or descend down. Autonomic features like urinary urgency, bladder or bowel incontinence, difficulty or inability to avoid bowel constipation, sexual dysfunctions also could be these features. Transverse myelitis is diagnosed by MRI scan. MRI scan features would be edema, thickening of the vertebral cord, the spinal cord at the level. There is abnormal thickening at the segment involved. That's a result of the edema, as you see in the CT scan. At the higher thoracic segment, you can see this, the edema and the thickening, which could be seen both in the transverse view or the other way. That makes the difference. See, difference in the MRI scan between transverse myelitis and GP syndrome is, in the GP syndromes there will be attenuation at the nerve root area, whereas here it's the edema of the spinal cord, the thickening of the spinal cord as a whole. Treatment, of course, once it is confirmed, the treatment would be glucocorticoids as such, like methylprednisolone, the same. So that's exactly the point. Now, a patient presenting with a limb palsy, sudden onset of limb palsy, now is prescribed with the glucocorticoids in the beginning, and IV immunoglobulins are prescribed only in the later stages, only after GP syndrome is confirmed. And in case of GP syndrome, prednisolone is of no use, or steroids would not be of much use, whereas in transverse myelitis, prednisolone started in the early days can produce a significant change in the outcome. There could be a significant recovery. Then plasma exchange therapy is common for both. So now in majority of the neurological centers where the plasmapheresis facilities are available, they prefer plasmapheresis as the first line of the treatment. Then IV immunoglobulins are reserved only for those conditions where the GP syndrome is confirmed. Then once it is confirmed that it is transverse myelitis, that immunomodulatory therapy like cyclophosphamide or mycophenolate or rituximab is the other prescription which is given for a long time, expecting the patients to recover. But majority of the patients would have a moderate recovery, and usually the patients would have some residual deficit. Extent of the residual deficit would vary, and a large number of patients would come to Ayurvedic treatment. Now, when a patient comes to me with the confirmed transverse myelitis, if it is confirmed already, because majority of the patients would have been treated earlier, otherwise it is the same issue. When a patient comes in the early stage, I would not treat that patient because of the risk of respiratory involvement, and hence the patient would be referred to a higher center. But if the patient comes in a stage with the flaccid paralysis, then my treatment would be Ama Chikitsa, Kaishora Murtyunjaya Amritaris and Agni Chikitsa. If the patient comes in the spastic stage, the treatment would be Ekangvira, Abhrakamishana, Ashwagandha and Yapana Basti, Raja Yapan Basti is the usual treatment, by which you may see a significant benefit over the treatment. I again don't say that the patient would be recovering completely, but there could be a very significant recovery as such. Prognosis in the patients, the recovery would be always partial. And if the recovery starts in the early stage, within 1 to 3 months, the outcome would be much better. But it may take very long time, and the debility may exist for a significantly long time as such. Rapid onset and complete paraplegia is a sign of poor prognosis in patients with transverse myelitis. With this we will conclude. Next we will discuss about the motor neuron disease in the coming session. So we will conclude today. If there are any questions, I will try to answer, and then so if there are some questions like GB syndrome, 90% recovery by modern medicine or by our medicine. See, in Guillain-Barré syndrome, if the patient has survived the first 1 or 2 weeks, recovery is a rule. The only question is about the time taken for the recovery, like whether it takes recovery occurs within a month, or whether it takes some 6 months or 1 year, so on. So exactly whether our medicine really benefits or not would be doubtful, but we will see large number of patients who find a significant relief after the treatment with our medicines, and the recovery rate would be faster. So that much is certain. And Tapyadiloha, of course, is from the usual resouchery which is available, where the Abracadabra and Tapya are mixed together. Right. So that's all the questions. Right. We will conclude today.